Mr. Keegan, for this part of it, when you list the members, if you want to just say who's here and then who will join us in the future, everyone who's missing.
Okay. Super.
I started a list for you on who's here.
That's awesome.
I don't know if it's easier for you to use that or...
Yeah, and you're probably going to have to add to it, right?
The mic is on.
Good afternoon. The first hearing of the Health Subcommittee Ways and Means will come to order. As members are aware, the full subcommittee organized earlier this year ratified our subcommittee assignments. However, I'd like to take the opportunity to introduce members on my side of the aisle, and then we'll recognize Ranking Member Levin to do the same on his side of the aisle. I'll just introduce members who are actually here right now, and then we'll recognize members as they get here later. So to my right, Mr. Adrian Smith from Nebraska, Ms. Lynn Jenkins from Kansas, and Mr. Kenny Marchant from Texas. With that, I will yield to the gentleman from Michigan.
Thank you very much. Mr. Thompson is next to me, a veteran member of this institution. And Brian Higgins, we welcome you back doubly. And others will be coming. We have votes at 2:15, I think, so I guess each of us will make a brief opening and then we'll vote. I yield back. Thank you.
Thank you, Mr. Levin. I look forward to working with members.
Our has arrived. We're just introducing ourselves.
With that, I will tell you that I look forward to working together, as we have talked about before, and I'd like to recognize our staff, and I will recognize Mr. Levin to do so on his side of the aisle. First, on the Republican side, Staff Director Emily Murray. Behind me, who is joined by our professional staff of Lisa Grabert, Nick Ulecki, Stephanie Parks, and Alyssa Palisi, and also down on the end there, our legislative assistant Taylor Trott, and my personal staff, Whitney Daphner, wherever she might be, and Abby Finn. Mr. Levin, you're recognized.
Amy Hall heads up our staff, Sarah Levin, no relation, and Melanie Egrin, and from our office, also Daniel. Thank you.
Well, it is my pleasure to welcome Mr. Miller back to the Health Subcommittee to help us continue the discussion on our Medicare program, payment systems, and extenders. It's time we took the next steps in strengthening our Medicare program. As the committee continues to look for ways to reform Medicare, the Commission's insights and analysis will be very valuable to our efforts. Today is a great opportunity for us to hear advice from a nonpartisan congressional support agency in order to better understand policies that will improve the program and ensure that we are making good use of taxpayer dollars. This year's March report brings us new information and data that should help strengthen our discussion in this particular area. In his testimony, Mr. Miller will highlight numerous inefficiencies in the post-acute care space. One statistic that I personally found quite staggering is that nearly $30 billion with a B in the current post-acute care baseline is being used inefficiently. Mr. Miller will also highlight the expiring Medicare extenders. MedPAC has commented on these programs over the years, and we will use today's hearing to give everyone a refresher course. Extending these programs has a cost, and every time we spend money in one area, we are making a decision not to fund priorities in other areas. Clearly, there are many areas that are in need of reform within the Medicare space, in the Medicare program. MedPAC has proposed innovative solutions, and I look forward to hearing more from the report. Meeting with Medicare providers around my district and state recently, there's been a resounding concern that I've heard from all of them, and that is overbearing regulations are increasing, burdening providers, and seem to be driving out and discouraging small providers in particular. I'm worried about the direction we're heading in this area. I'm hopeful that my colleagues on this subcommittee, the Full Ways and Means Committee, and this Congress can work together with the new administration to not only spur innovation, but reduce regulatory burdens across the Medicare program. With that, I'd like to introduce today's witness, Mark Miller, the Executive Director of the Medicare Payment Advisory Commission, MedPAC. Welcome back, Mr. Miller. And before I recognize Ranking Member Levin for an opening statement, I ask unanimous consent that all members' written statements be included in the record. Without objection, I recognize Ranking Member Mr. Levin.
Thank you very much, Mr. Chairman, and it's a pleasure for all of us to work with you and your colleagues. And to you, Dr. Miller, thanks for joining us today and for the important role that MedPAC plays in informing Medicare policy. We've had a chance to look at your report, maybe not read each page of the long one, but an excellent executive summary. And unfortunately, as Mr. Teaberry and I have discussed, this is the first hearing of this subcommittee. And I regret that we did not have an earlier hearing on the consequential health legislation that the Republicans introduced and passed. That bill, as we know, would have taken away coverage from 24 million Americans while handing out nearly $1 trillion in tax cuts, primarily for the wealthy, indeed the very wealthy, and corporations. It would gut Medicaid by cutting more than $800 billion from the program and shifting costs to patients. It would allow states to eliminate or weaken crucial market reforms, including essential health benefits, community rating, and protections for older workers. It was opposed by doctors, hospitals, patients, AARP, almost everybody who is a participant in the work that you do, Dr. Miller, though all of our colleagues here on the Republican side did vote for it. But this hearing is about Medicare. With all that is deeply harmful in the basic law or legislation that the Republicans passed, there's been much less attention paid to the damage that bill would do to Medicare. The bill eliminates 0.9% payroll tax on high earners, depriving the Medicare Hospital Insurance Fund of $75 billion in order to benefit people making more than $200,000. It grants a windfall to wealthy investors by eliminating the tax on unearned income, including capital gains and dividends. And it would provide a $28.5 billion tax break to pharmaceutical companies, which will create a shortfall in the Part B trust fund. Beneficiaries will be directly responsible, if that were to pass, for a portion of this shortfall, causing an $8.7 billion premium increase. These provisions would shorten the solvency of the Medicare trust fund. What's more, they would fundamentally break a promise we heard over and over again from the President that he would not cut Medicare or Medicaid. The Republicans have also neglected to address other important issues that Medicare faces, and let me comment briefly on perhaps the most important one, the prescription drug spending crisis. I hope we can spend some time today on that. Skyrocketing drug costs have devastating consequences for the middle class and for federal health programs. The Medicare trustees have told us that program spending in Part D increased by 15% in 2015 alone. In Part B, GAO has found that Medicare often pays more for physician-administered drugs than other federal payers, including Medicaid and the VA. MedPAC has made a number of recommendations to address Medicare prescription drugs spending. Notably, the Commission has pointed out perverse incentives that impact industry behavior and contribute to higher costs for the public. So I hope this hearing will provide us an opportunity to discuss this and other important issues that you raise with so much depth, Dr. Miller, in your report. I yield back.
Thank you, Mr. Levin. I want to remind members that this hearing is called the Medicaid hearing on the current status of the Medicare program, payment systems, and extenders. I gave tremendous leeway to Mr. Levin in his opening statement, more than ever has been given to me in the minority, but we are going to keep this topic from here on out on the topic that was given to members when this committee hearing was released. And before I ask Mr. Miller to begin, I just want to recognize some constituents in the audience. Mr. Mike DeManna, a teacher at Orange Middle School in Delaware County, and some 8th grade students. Can you stand up in the back? Mr. DeManna, are you back there? Did you leave already?
Is there anybody
left?
Is there anybody here from Michigan?
Oh, no. They heard a guy from Michigan and they all bolted. Just kidding.
That's carrying rivalry too far.
Mr. Miller.
So Michigan beat Ohio State. Is that what happened?
It's been a while. Mr. Miller, you're recognized for 5 minutes. Thank you.
Thank you. Chairman Teaberry, Ranking Member Levin, distinguished committee members, I'm Mark Miller, the Executive Director of the Medicare Payment Advisory Commission. And on behalf of the Commission, I'd like to thank you for asking us to testify today. As you've already mentioned, we're a small, independent congressional support agency required by law to provide analysis and recommendations to the Congress. Our work in all instances is guided by 3 principles: assuring beneficiary access to high-quality care, protecting the taxpayer dollar, and paying providers and plans in a way to accomplish these goals. With respect to the program's status, Medicare spending is about $650 billion annually, 3.5% of GDP. Given the enrollment of the baby boom and rates of spending per beneficiary, the Medicare program is projected to grow faster than the economy is projected to grow and continue to raise issues of affordability for both the taxpayer and the beneficiaries that finance the program. By law, our March report makes a series of payment recommendations on various fee-for-service sectors. Each year we produce analysis on access, supply, utilization, the private equity markets, quality, and financial status. I have recommendations across a range of fee-for-service sectors that I can discuss, but I want to focus on the fact that over the last many years, the Commission has paid particular attention to the post-acute care sector. I'm referring to skilled nursing facilities, home health agencies, inpatient rehabilitation facilities, and long-term care hospitals. The Commission has made recommendations to restrain unnecessarily high payments, improve the equity of payment systems for both patients and providers, improve quality measurement, and also to direct the Secretary's attention to program integrity issues. For 2018, we recommend a 2-year payment freeze for skilled nursing facilities, a 5% payment reduction for home health agencies, and a 5% payment reduction for inpatient rehabilitation facilities. Medicare profit margins in each of these sectors is 13% or more and has been that way for over a decade. In each of these sectors, we are again recommending that changes in the payment system would be made so that we pay more on the basis of patient need, and that will result in greater equity across different types of providers. We believe that if the Congress were to follow this recommendation, something like $30 billion over the next 10 years in unnecessary payments could be avoided. In other reports, the Commission has recommended moving away from the siloed approach to post-acute care delivery and instead move towards a unified payment system for post-acute care providers. And again, pay on the basis of patient need rather than site of care, and also this would increase the potential to measure quality of care more accurately. Turning to Part C and Part D, managed care and Medicare has continued to show strong growth, currently accounting for 31% of enrollment, and there are multiple plans available in virtually every county of the U.S. On average, plans are bidding below fee-for-service, which is a significant improvement since 2010. The dollar value of extra benefits that they provide has been increasing, and the Commission has made a few recommendations in this area, most notably to recapture payments from excess coding that targets plans that are most aggressively engaged in that coding, And we've also recommended increasing the overall benchmark in MA in order to treat plans more fairly. In the Part D drug program, beneficiary enrollment has been increasing, and there continues to be access to standalone plans, managed care plans, and plans for the low-income population. Overall, spending growth is about 7% annually, but the portion of the program paid exclusively by the government has been increasing at an annual rate of 20%. This is because the number of beneficiaries reaching the catastrophic cap has accelerated over the last few years. They currently account for more than 50% of the spending. The Commission has made 3 recommendations in this area to address this problem, but most notably, we recommend shifting more risk to the plans for these catastrophic costs and couple that with additional tools for the plans to manage that risk. With respect to extenders, I will note that over the last several years, the Commission has done work on ambulance payments, including a more targeted rural assistance policy, therapy caps, where we've tried to strike a balance between cap restraints and exceptions for needy beneficiaries, and then we have specific recommendations on each of the special needs plans categories, and finally, we've made several proposals for rural hospital payment adjustments. And with that, I'm happy to take your questions.
Thank you, sir. Mr. Miller, your testimony reflected some of the Medicare extenders in writing, and these programs that our Congress needs to address and determine whether we should extend them or not. Many of these programs have been extended several times in the past without any policy modifications. And by the way, for members, that's a vote that's occurring, and there are 2 votes, my belief is, and so we're going to begin asking questions, and Mr. Miller has agreed to sit tight while we go vote and come back. So I'm going to begin the questioning, and if you feel you need to skedaddle over there, please do, and please come back after the votes.
We'll come back.
Yeah, we'll come back. So Mr. Miller, can you talk through each of the extenders and what MedPAC has concluded about each one of them?
In 5 minutes, that's a little bit difficult, but I'll do that. Well, what I do want to say really quickly is all of this has analysis and detailed work behind it, but I'll just try and hit you with the top line. Special needs plans. We've made recommendations for each of the categories. We've recommended continuing the institutional special needs plans. With respect to Part D special needs plans, we've recommended that you continue those, but you have a requirement for integrated care between Medicare and Medicaid. For the chronic care special needs plans, we have said that for dominant conditions like AIDS and ESRD, they make sense, but for conditions like diabetes, congestive heart failure, we would create greater flexibilities in the regular MA plans to basically replicate a special needs type of model in the regular plans and would discontinue those. On therapy, or on hospital payment, there's a low volume adjuster, which we originally made recommendations that the Congress should take up, which it did. And with all respect, our point here is that it hasn't been constructed properly. It keys off the number of Medicare admissions when it should key off of the total admissions. And I can take that up on questions in just in the interest of keeping moving along. We also think that there are adjusters like Medicare-dependent hospitals, those types of adjusters. And the 2 concerns I'll express there is often you can get 2 adjusters that are aimed at the same problem. Medicare-dependent hospital, a low-volume adjuster, as the case may be. We think you should be very conscious of duplication, and when the adjuster goes to the provider, be conscious of the distance it is from another provider, because you don't want to be sending a subsidy to 2 hospitals that are, say, within 10 miles of each other, and you're basically propping up 2 operations that are having a hard time meeting their fixed costs. On ambulance, we generally let the extenders expire and then reorganize the fee schedule to focus more on less on basic life support transports and more on advanced life support, basically rebalance the payments there. And then we also took one of the adjusters for rural providers and targeted it to low-density counties where you'd have a harder time covering your fixed costs. I can stop anytime.
No, keep going.
Therapy on the therapy caps. What we said there is that there is an extreme variation in the utilization of outpatient therapy. I want to be really clear. We think it's a very valuable benefit, and we're thinking that there is evidence that it helps beneficiaries, but we also think it's relatively open to abuse. So we would adjust the caps downward to about the 70th percentile of the distribution, but couple that with a review of exceptions that makes specific decisions about the exceptions outside of the cap instead of a blanket checkbox type of exception. I'm going to stop there. I'm sure I've left something out, but I'll...
Okay, we can come back to it if you remember later, or we can ask you a question on the second round.
I'm sure I left something out.
So Mr. Miller, you and I have had private discussions in the past about the freestanding emergency departments that are popping up around parts of the country, and there seems to be a new one popping up every month or so in my state of Ohio. This is a topic that I know MedPAC will be publishing in its June report and be released about a month from now. Can you give us a preview? Are you allowed to do that?
I'll do that. I'll also go back a little bit in history. We've talked about this in our June 16 report, and we've also talked about it in our March, or the report we're talking about here. This is the one where we said that we should be collecting claims identified for on and off campus, because we're really blind right at the moment and kind of analyzing this phenomenon. The commission is very concerned about this. There has been a lot of growth. There is concern that growth is occurring in markets where they're either saturated or relatively high income, not necessarily poor populations. And in June, we won't have additional recommendations, but we're going to identify 3 or 4 issues for us to think about and then come back with recommendations. So one thing we're beginning to get concerned about is that the mission of an off-campus emergency room may not, in the patient population and the intensity of service, may not look like your standard on-campus emergency room. And so maybe, we need to start thinking about a payment structure that reflects the fact that they have a different patient mix and in some ways a different mission. A second thing is that, well, I'll hold that one for last. A second thing is in the legislation that the Congress passed on site neutral, where the Congress was saying after a certain date, if you purchase a physician practice, you don't get the richer outpatient rates. We're concerned that there's a provision in there that if you attach services to an emergency room, you can actually get around that prohibition, and we'll be discussing that. The last thing I wanted to bring up is in the rural areas. We think there may be a role for freestanding emergency rooms in isolated rural communities, or in isolated rural communities that don't have the patient population to support a full-scale inpatient operation. And we have ideas that we've been talking through where you could restructure the inpatient subsidies and support freestanding emergency rooms in isolated rural areas. So it's not that freestanding emergency rooms have no role anywhere. We have concerns about their growth in certain areas of the country, and then we think we're probably not got quite the right incentives out in the rural areas.
One follow-up. So if you have the Diane Black main hospital, so you have the main hospital with the main emergency department, and then 10 miles away you have the freestanding Black emergency department. Does Medicare get data on the visits to that 10-mile-away facility, or is it part of the main hospital emergency?
It's all mashed together.
So Medicare, or you at MedPAC, you can't discern if I go to the freestanding one or the main one.
And that we cannot, and we are concerned about that, and that was the recommendation we made here in this report, to say that CMS should begin to develop a modifier so that when this claims flows comes in, we know it's occurring on or off campus.
Great. So we're going to go. Thank you so much.
You got a break.
When we get back, I'm going to yield to Mr. Levin for his questioning, and we'll be back in a few minutes. Thank you. This hearing is recessed until we get back. Thank you. All right, our hearing is going to come back to order. We've been joined by a few of my colleagues who weren't here when I did the introduction, so I want to just recognize the members who are here now. Peter Roscom from Illinois, Eric Paulson from Minnesota. Did I say that right? Minnesota? And Tom Reed from New York. With that, I will yield 5 minutes to the gentleman from the state up north from Ohio, Mr. Levin.
You're still bitter about some of the back and forth between our two states. I don't think Ron Kine was here when we introduced ourselves, or Judy Chu. And Earl was here part of the time. So, Dr. Miller, welcome. As I read your report, your testimony, and also the executive summary, I was just struck by the thoroughness of the work you do. A lot of the issues are controversial. I remember when we first talked about controlling payments to physicians and the heck that we received and how much controversy there was. And you thought the sky was falling and it would never work out for physicians. And I mention that because I really think your report, and it has areas where there are differences of opinion, your report shows how successful this has been, this program that is in some respects a public, but not only public, but public and private partnership. And with a lot of back and forth from the private sector as reflected in your report. And I just want to comment for each of us on this committee, on this subcommittee, when we go home, we have lots of meetings with the various providers, the various groups, and they have differences of opinion, and they have some urgent pleadings. But I really think your report shows why Medicare is such a necessary and popular program for the people of this country. And not only for those who are covered by it, but by their families who benefit because those who are older than others in the family have the security of health care. So, without saying I agreed with everything you said, I wanted to congratulate you on your work. And I hope, Mr. Chairman, that we'll be able to have some further discussions in depth about each of these important components, because I think there's a danger that each of us kind of picks and chooses one particular area where we think there is a special problem or grievance, instead of looking at the program more comprehensively. So let me start off. I think others are going to follow up on this because prescription drugs has become so urgent an issue. Begin to discuss with us how MedPAC has begun to look at this issue, and my time will run out and others will carry on. Thank you.
If I could just say one thing, I'd like to thank you for saying that. Remember, I have a tremendous staff, and also GAO has done a great job of appointing solid commissioners. So that's why you have the work that you have in front of you.
Well, thank you, Mr. Levin. With respect to the issue that you just brought up, I think that that's a really good suggestion in terms of looking at these things together, and I hope that we can do that in a bipartisan way.
No, I would like to. So start talking about prescription drugs. You have 48 seconds, and others will carry on.
Okay. We've done two areas of work in prescription drugs. Most relevant to our current conversation is in Part D. What we've seen is, generally you look at Part D, more beneficiaries are being covered. People have high degrees of satisfaction, and the premiums have been relatively level in Part D. But if you look a little bit closer at the program, there's a portion of payment that is covered by the federal government exclusively, the catastrophic portion of the benefit, and that's been growing at a rate of about 20%. And so the Commission has been concerned about that growth rate. There's a couple things that are...
So, Mr. Chairman, you want to gavel me down, and Dr. Miller, others will carry on. So
Okay.
I keep within the time limit. Thank you.
Did you want me to gavel you down?
No, but
That's unusual.
no, but I think everybody wants their 5 minutes. So.
Speaking of 5 minutes, the gentleman from Illinois is recognized for 5 minutes.
Thank you. Dr. Miller, thank you, and I'll pick up on the little bit on the holistic theme of Mr. Levin. That is, there's a general recognition that Medicare is a program that everyone celebrates. To his point, let me bring up a particular concern that's been brought to my attention based on feedback from an inpatient rehabilitation facility in my district, and really one of the leading ones in the Midwest. The concern is that the March report recommends an aggregate reduction in payments by 5% for that group. And I'm talking specifically about those that are in the nonprofit sector. Their margin is only 3.6%. And so this is parochially, this is a crown jewel rehabilitation facility in my constituency. Their margins right now under Medicare are minus 20%. So the notion of putting more pressure on them is difficult to fathom. Can you give me a perspective on that? Is this a final word? Is this dispositive? Are you looking for feedback? Kind of what's the state of play? I mean, I guess the first question is, do you agree with my characterization? And if so, then what can we do about it? If not, why not?
Okay, so I think you've asked and made a completely fair comment. We've talked to a ton of inpatient rehab facilities and people in the industry, and we do understand the phenomenon, and our data makes your point very clearly. So in the post-acute care sector in general, and in the inpatient rehab facility sector in particular, what you see are very high aggregate margins, and then you see differences in financial performance. And as you said, it often is between for-profit and not-for-profit, but it's often tied to what kinds of patients that the different facilities tend to focus on. There's a whole section of the report. I won't go through it in a lot of detail because I know we're under pressure here in terms of time, but we have seen coding practices that raise questions, patient selection types of practices that have raised questions. So what we've tried to do is, in all of these instances, is say, okay, total payments can be lower, but they have to be redistributed across the different kinds of providers. And we generally try and do that by tying the payment to particular types of patients. And so if you're taking medically, the more medically complex, we would tend to shift the payments in that direction, which would have the effect of creating better or more support for the kind of facility that you're talking about. In the patient area, and here's the last thing I'll say, and you can get back in, I'm sorry. In the inpatient rehab sector, the other thing we said, in addition to bringing it down, is to increase the size of the outlier pool so that more payments would come out of the general payments and go to those kinds of facilities that have the financial circumstance that you're talking about. So where there was a recognition and an attempt to get at that. And then we also think there's some coding practices that the secretary or the IG or people like that should be looking very hard at on the very profitable side of the industry.
Okay, thank you. That's helpful for me, and maybe we could engage further. This is the white knight sort of place that you want to be successful. They're doing, from my point of view, all the right things. So this is exactly the type of facility.
More than happy to talk to you about that.
Thank you. Yield back. Thank you, Mr. Chairman.
Thank you. Mr. Thompson, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you for having this opportunity to talk with Mr. Miller. Mr. Miller, thank you for being here. I appreciate the work that you and your staff do a great deal. As you probably know, in March, this committee approved legislation. The Republicans did, the Democrats voted against it unanimously. That was a $1 trillion tax cut that included $75 billion reduction in the revenues in the Medicare Trust Fund. And it's my understanding this is obviously going to shorten the life of the trust fund. Do you know, were there any provisions in that legislation, or do you know of other legislation that would codify any of the recommendations by MedPAC to save enough money in the Medicare program to cover that $75 billion loss?
I'm not aware of legislation that would offset that loss, if that's what you're asking me.
The which?
I'm not aware of legislation that includes MedPAC recommendations that would. Yeah.
So $75 billion taken out of the Medicare program will affect the access to care for the millions of Americans who rely on that?
I can't comment on the effect of that particular provision, but your other question, I'm not aware of an offset for it.
Does MedPAC have recommendations to find $75 billion worth of efficiencies?
I am going to interrupt here real quick. So just a reminder, this is about MedPAC's report, recent report, as well as the extenders.
That's what I'm asking, Mr. Chairman.
About the report, the March report?
I'm asking if there are recommendations.
In the March report?
In any report.
This
Are
is
there
about the March
recommendations by MedPAC that would cover the $75 billion loss that was brought about because of the legislation that was passed by the Republicans in this committee in March?
So without, comment on the pending legislation, there are an array of recommendations in the MedPAC report that result in savings. And so, for example, the post-acute care things that we just talked through, we don't do estimates, that's CBO and all the rest of it, but we think we're talking in the neighborhood of $30 billion. I mentioned the MA coding issues. I mean, there's potentially savings there, for example. We also think, the changes in the Part D recommendations could yield savings. And then also there's a couple of other places we haven't even talked about where we restrain the updates that would produce savings.
So those savings, the $30 billion worth of savings, how would they come to fruition? Would it require legislation?
Almost everything I have referred to would require legislation. I have to think about that for a second, but yeah, generally legislation, yes. So
of the $75 billion that will be stripped from Medicare because of this American Health Care Act, you can identify possibly $30 billion that could make up some of that difference, but that legislation, but to get there, we'd have to pass separate legislation?
Yeah, to get to $30 billion, you have to pass separate legislation, and there is more, I don't know that I could ballpark the number for you. There's more savings in that report than the $30 billion.
And that additional savings, would that require legislative action?
I think as a blanket response to your question, in general, it would require legislation.
Do you happen to know if any of that legislation has been introduced?
I don't happen to know that.
So we have a $75 billion hole in Medicare with no legislative attempt to address that loss.
I'm not aware of introduced legislation. I wouldn't necessarily be the person who would be aware of introduced legislation.
Are you the person, or could you, in your position, give us some idea of what sort of problems a $75 billion loss to Medicare would bring about?
Again, on that particular provision, I don't feel real versed in talking about what the implications of it would be.
Thank you very much.
Gentleman's time has expired. Mr. Smith, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you, Dr. Miller, for your presence here today. And certainly, your responsibilities are large, and we've got a big job to do. So we appreciate your efforts. It's no secret that rural America has some challenges, especially with the agriculture economy and many of the challenges at access to care. Critical access hospitals are very important to serving the rural population of America, and I know that they face challenges with funding and so forth. But one concern that I've been working on, and my colleague Ms. Jenkins has as well, is the enforcement of the physician supervision requirements for critical access hospitals. And as you know, these rules require a physician's presence and supervision over nearly all routine procedures administered in hospitals. And this arbitrary regulation has been especially burdensome for hospitals and doctors in the very rural areas. It seems unnecessary, but the 21st Century Cures Act requires MedPAC to report to Congress on the economic and staffing impacts of this regulation on rural hospitals by the end of this year. I was just wondering, we're about 6 months in already. I was wondering if you might have an update on what has been found so far, if anything.
I really don't at this point in time, and I don't mean to be unhelpful, but I don't have anything to say about it at the moment.
Okay. Well, I would hope that we can have as much information as is practical and possible in a timely fashion. To look at another issue, shifting gears here a little bit, I know that in the past the Commission has recommended allowing the ambulance add-on payments expire. Despite this recommendation, I know I hear from suppliers in my district that they need these payments. Is there any cost report data available to CMS that indicates these payments are needed in rural areas?
My understanding is there is not cost report data available, and I think there has been discussions in the environment. We had some discussion in our particular ambulance report about how cost reports could potentially work. One big issue in trying to go after it is there's very large, or even reasonable size operators where submitting a cost report probably makes a lot of sense, but you also probably have a segment of the industry where you're talking about volunteer fire departments and that type of thing where, a full-scale cost report is probably something of an issue. There's probably a way to square that circle, a relatively slim cost report that, and ambulance providers, and then excluding certain small ones from the reporting requirements, which might be a pathway. That's nothing the Commission recommended, but there's sort of a discussion to that effect in our report.
Okay. Well, I appreciate that. I know that one-size-fits-all approach is not always helpful. In fact, it rarely is. And as rural providers do face these challenges, I hope you'll certainly keep in mind the flexibility that oftentimes needs to occur. And I appreciate your efforts.
And I do want to, unless we're done, I do want to say in our recommendation, this principle that I tried to say in the introduction of, if you're going to provide support for rural providers, which the Commission fully supports, it's really about targeting, not duplicating, not supporting, two providers who are right next door to each other and maybe, in effect, not able to fully cover their fixed costs, and then you're trying to subsidize both of them. And so in the ambulance situation, we took one of the add-ons that was targeted to rurals and redistributed and targeted to counties that had very low population density. We end up covering about 75% of the same areas, but you can provide a much larger subsidy. And basically, you're moving the subsidy away from places that are near metropolitan areas and giving it more truly to the isolated areas. And in our opinion, and people disagree, making that dollar go further.
Okay. Thank you. I yield back.
Thank you. Mr. Higgins, you are recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Miller, the New York Times on Monday reported that United Healthcare, among the largest private health insurance companies in America, is being sued for defrauding the American people in the Medicare program under the Medicare Advantage program, estimated to be between, well, billions of dollars each year out of the past decade. The article also went on to name 4 other private insurance companies that participate in the Medicare Advantage for defrauding the federal government and the Medicare program as well, potentially tens of billions of dollars each year. Yesterday, the Department of Justice joined that lawsuit and is rigorously investigating those allegations. If these allegations are true, that would represent among the most egregious defrauding of a federal program in a long time. What is your knowledge of this? And my understanding is several audits have been done over the last several years that identified a problem, and why hasn't more decisive action from an administrative point occurred, which presumably the consequence of which is this legal action.
So let me try and answer what I think might be 3 questions in there. Yes, we're aware of the lawsuit. In fact, we've gone through it in some detail ourselves, just as a way of educating ourselves, and I agree with you, there are some relatively egregious things in there. I don't know how much of it you got into, but the email traffic back and forth among the company and people in the company is certainly an issue. Number 2, on the auditing, and then I'll get you to something. On number 2, on the auditing, obviously, we're a small operation. We advise the Congress. We don't do any of that oversight. That falls to CMS. But what we have been doing is we've made estimates of looking at, over time, the coding in managed care plans relative to what is assumed and built into the risk models. We think that there is excess coding occurring, and we have recommended that it be taken out. And we've also recommended that it be taken out differentially based on how much activity is occurring within the plans. And the only other thing I want to say, and I want to say this carefully because you may have a different view, not all of it is fraudulent. Yeah. Plans are collecting these codes in order to understand what their mix of patients are.
Let me just reclaim my time. This is not one company. It's the largest provider under the Medicare program. 17 million people in this country get their health care under the Medicare program through Medicare Advantage. It's 4 others as well. So that says to me that this is a systemic problem within the system that needs to be fixed because they're defrauding the American people and the Medicare program, number 1. Number 2, the CEO of United Healthcare in 2014 was compensated $66 million, 1 person, 1 salary, 1 year. The Republican health care bill that was passed by this House included, on page 67, a $15.5 million tax cut to United Healthcare's CEO and their top executives, $15.5 million. In total, the other companies that are being questioned for overbilling, defrauding the Medicare program, that bill provided their top executives with a $78 million tax cut. At the same time, that company and 4 others are under investigation for defrauding the Medicare program. You can parse it any way you want. To me, it is a blatant violation of the trust that every member of this Congress took an oath to uphold and to protect. I'll yield back.
The gentleman's time has expired. Mr. Miller, thank you for attempting to answer that question. I want to remind my colleagues of the scope of this hearing, and I am going to give an opportunity once again, to remind everybody of Mr. Miller's valuable time in the scope of this hearing. I don't want to get into tit for tat. The allegations that the gentleman brought up are very serious. Individuals or companies are innocent until proven guilty. But I want to also remind my colleagues, and I don't want to waste Mr. Miller's time to get into tit for tat about the American Health Care Act or, quite frankly, the Affordable Care Act, because we could spend all day debating with each other about the Affordable Care Act or the American Health Care Act. Mr. Miller and his staff have graciously given their time today to talk about the report and how we can work together in a bipartisan way to improve Medicare. And I hope my colleagues will spend the rest of the time respecting Mr. Miller's time on how we can work together in implementing some of those recommendations. With that, I will recognize the gentlelady from the great state of Kansas for 5 minutes.
Thank you, Mr. Chairman, and thank you, Mr. Miller, for being here. Medicare is a program that was created with a promise to our seniors, and we talk a lot about how we're going to keep that promise and reform the system to shore it up. One way to improve the long-term viability of the trust fund and the care paid for by that program would seem to be to move to a value-based payment model for services that have not yet moved in that direction. In your March 2017 report, MedPAC points out that skilled nursing facilities are able to control the amount of money Medicare will pay them based on their current payment model. I just wanted to get your sense of the impacts of a move to a value-based payment model in the skilled nursing facility space. So just a couple questions. The American Health Care Association has a value-based payment idea that the March 2017 report discusses. It states that the model, while reducing payments to for-profit facilities, will increase payments to non-profit facilities. Could you talk briefly about MedPAC's belief that the idea will strengthen the skilled nursing facility system as a whole?
So if I follow the question, and if not, just redirect. There's a few things that I think we're saying that you're responding to here. The first is not dissimilar to the conversation with Mr. Roscom. Inside the SNF, the skilled nursing facility payment system, we think overall spending is too high, but we also think that the way the system is currently structured, and we can get into some of the technical, but for the moment, just trust me, the way the system is currently structured, it is not paying properly for different kinds of patients. So it incents people to take sort of your basic physical rehab patient. It incents avoiding the complex medical patients. The recommendations we've made would be based on patient need and bring a greater balance, we think, and improve the value for the beneficiary, a greater balance in how that payment works. And you mentioned quickly the not-for-profit, and for-profit. That isn't about making the payment system peculiar to for-profit, not-for-profit. That just happens because the way the payments shift based on the patients that those two different types of providers take. The other two quick comments on value, and I'll get out of your way, is we do talk about the notion of tying payments to different outcomes, avoiding returning to the hospital, avoiding going to the emergency room. And then we have other conversations about reorganizing the entire payment system, having a unified payment system, but also ultimately moving towards more episode of care in which inside the clinicians would have the flexibility to engage in practices and delivery practices that they would hopefully bring lower cost and higher quality. So we have a few threads in this particular area.
Okay, just to follow up on that, the reform payment system proposed by the American Health Care Association is based on the creation of clinical groupings that would include an array of different patient types, and CMS has studied this type of payment basis. And I'd like to know if you believe that a move to patient characteristics instead of length of stay is feasible for CMS and providers, and if it results in a better outcome and cost savings?
Yes. And our work sort of, we think, the starting point for this thought process, where we constructed a different way to do the payment system based on patient characteristics. And we have models that do that. And I think what you're referring to, the industry's notion, is taking that and sort of aggregating it up into patient categories. And as long as the underlying, tying of payment to patient need is not lost in the process of doing that, then it's consistent with the direction that we've been talking about going in.
Okay, thank you, Mr.
If
Chairman.
I
yield back.
follow what you're saying.
Mr. Blumenauer, you're recognized for 5 minutes.
Thank you, Mr. Chairman. We appreciate your being here. MedPAC over the years has helped deconstruct the hopelessly complex system that Congress routinely makes more complex, and helping us dive into some of the details that otherwise we wouldn't have. And I appreciate the chairman's latitude so we can explore some of this, because otherwise we wouldn't. And I'm hopeful that one of the things that will, once we can move past some of the current controversies, we can do a better job of diving into what some of these elements are, to understand them better, look for areas of being able to rebalance some of the complexities, coax more value, and incent more appropriate behaviors. Because regardless of what happens on Obamacare or the Republican bill, we still pay about twice as much as anybody else in the world, and too many Americans get mediocre to poor care. The people in Canada and France and Great Britain and Japan live longer than we do. They get well faster. They don't get sick as often, and they pay far less. And you're helping us understand some of the elements that are a part of that, and how we can use some of these large healthcare programs that we finance to get better performance. I want to turn to one specific item that you had in your report, talking about hospice. This is an area, in part because of our death panel work over the years, spent a lot of time dealing with end-of-life care, hospice treatment. And in your report, you reference that people can get this Medicare hospice benefit if they are terminally ill with a life expectancy of 6 months or less. They can elect the Medicare hospice benefit, but they agree to forego Medicare coverage for conventional treatment of terminal illness and related conditions. I would like you, whether you may not have hard data on this, I know there is a pilot project currently underway looking at what the implications are for continuing curative care while allowing people to access the palliative care in terms of hospice treatment. I think there is some evidence that this is a decision point for people approaching hospice, that it's a difficult decision to be in that mindset, kind of letting go, foregoing a curative. It has kind of a note of finality to it. I wonder, and if there aren't some incentives, therefore, for some people who would dramatically benefit from hospice care, they and their families, and maybe scale down some of the curative activity, if it didn't have to be an either or. Could you comment on whether or not there might be some savings overall in terms of health care if people were given hospice care that might be more appropriate to them and not force them to jump off that cliff?
I am aware of the issue. The issue has come up a couple times in the commission conversations. There is no inherent hostility to the notion. A couple thoughts just to follow up on. You're right, there is a demonstration or some kind of pilot out there, and we are looking to that to sort of see the answer to some of these questions. It's very hard to get your arms around it because the counterfactual is always difficult to sort out. We also made recommendations that hospice should be included in the MA benefit, which it currently isn't. We're in a full, episode beneficiary structure. The notion of those trade-offs being made by the clinicians on the ground makes a lot more sense. This is this typical problem where it might make sense in a certain context, but you take it out into fee-for-service where a lot of different things and a lot of people can get involved. It becomes harder to be sure that you're really making the trade-offs. Again, it's not a hostility to it. It's a concern whether it really plays out the way people hope it will play out in fee-for-service. We're looking at that demonstration too.
Thank you, Mr. Chairman. I wholeheartedly concur with the notion that it ought to be wrapped into Medicare Advantage.
Agreed.
It makes a lot of sense. And watching this pilot project, if there is a way to feather it in some fact to get the best of both. And I appreciate having a chance to talk about this.
Thank you for your leadership in the hospice area, sir. Mr. Paulson, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and Mr. Miller, thanks for being here today and testifying on a very important topic, obviously, on the future of the Medicare program. I do think it's critical for members across the board to have a very firm understanding of how the program operates as we look for ways to continue to strengthen Medicare for the future. And as has been discussed, the Medicare Advantage program plays a pretty critical role within the Medicare system. Almost a third of all beneficiaries around the country are now enrolled in a Medicare Advantage plan, and those numbers are only going to continue to grow. They're projected to also continue to grow. I know in Minnesota, our seniors are particularly interested in enrolling in MA programs. Last year, I think 55% of Minnesota seniors were enrolled in an MA plan, which is actually the highest in the country. And that's why I remain focused on ensuring that this program is going to continue to deliver high quality benefits for seniors. So the report that you released in March, it highlights the growing trend of seniors in the fee-for-service plans choosing to enroll in Medicare Part A only instead of enrolling in both Medicare Part A and Part B. And given that Medicare Advantage enrollees must enroll in both Parts A and B, can you briefly discuss the impact of more beneficiaries enrolling in Part A, of what that's had on the MA program?
Yeah, and you've picked up on something that we said in the report and talked about in the report. So you are getting more of this phenomenon of beneficiaries being enrolled in A only or B only, but really, the B only is kind of a small phenomenon. It's really the A only. And so what happens in that circumstance is if you're an A only beneficiary, your expenditures tend to be below average. And then if you think about the way the payment system works, which you sound versed in, for a given county, you accumulate all the fee-for-service beneficiaries and you set a benchmark, and then, there's some administrative adjustments to that benchmark. Plans bid against it. And so what we started to become concerned about is to the extent that you get more A only, and somewhat this is geographic in its impact across the country, but we're concerned it's going to grow over time. You're basically saying I'm going to set a benchmark that includes a large body of people or a growing body of people that the plans can enroll, and it compresses the benchmark. And so we've said, this is something that CMS needs to look at because it may need to be a different way to set the benchmark using the AB, just to use jargon for a second, the AB beneficiaries in setting that benchmark. Now I want to quickly add something here. So this would add costs, because it would potentially raise the benchmark that the plans are bidding against. And we have pointed out at the same time that there is this coding phenomenon that also needs to be taken into account, and those dollars need to be taken back out.
So let me just follow up on that. I mean, just looking at, you mentioned the possibility of adding costs, but can you just mention what would the benefits be to the beneficiaries themselves if we move to that system of calculating the Medicare benchmark only using data of fee-for-service, beneficiaries enrolled in both Part A and B?
Well, I hadn't thought about the question quite that way, so I think it's a good question. I mean, what happens now is to the extent that you bid below the benchmark, a portion of that dollar has to be converted to a benefit that goes back to the beneficiary. Mostly plans do it through lower cost sharing. You know, arguably, if the plans are basically bidding below the benchmarks now and offering those additional benefits. If the benchmark went up, in theory, they would be able to offer, you know, in theory, all else equal, and there's a lot of behavioral response out there, they would be able to, you know, if they can continue to bid below that benchmark, which in theory they should be able to offer more benefits.
All right. Thank you, Mr. Chairman. I'm also hopeful, thanks, Mr. Miller, that over the next few months we'll be able to also continue to examine and explore and address the expiring Medicare extender policies that are in place, such as the therapy cap, exceptions process, the ambulance add-on payments, because I think it is critical that we ensure there's not a disruption that are those critical services that are provided to seniors around the country and they rely on as we strengthen the overall program in the future. So thank you. I yield back.
Thank you. Mr. Kine, you are recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Miller, thank you for your testimony here today and the good work that you and your staff do and the report that you submit to us every year. And just to follow up with my friend and colleague from Minnesota, I appreciate his interest in it, and I also appreciate the MedPAC's report as far as the benchmark caps and what you're recommending. And for my colleagues' edification, I introduced legislation last year, H.R. 4275, along with our colleagues Mike Kelly, Mike Doyle, and Brett Guthrie, that gets at this very issue as well. So we're glad to see MedPAC focusing additional attention on the benchmark cap issue. And we'd be interested in following up with you as far as any type of cost impact that this is going to have, a little bit more data that you're looking at that would benefit us in the legislation that we're moving forward. Also, along those lines, you're probably aware that Chairman Brady and I have introduced a post-acute care reform bill in order to begin the conversation and start getting feedback. We're appreciative of the effort that MedPAC and Paul, you in particular, the work that you're doing in this field. We'll be looking forward to following up with you on policy recommendations because we feel that there's more coordination, more integration that can be had, more efficiency, better outcomes at a better price within the post-acute care world, and that might be the next iteration of healthcare reform and where we can get better outcomes at a much better price, cost savings ultimately. So we'll try to follow up with that. And then I too share the concern that we've heard here from the dais from a number of my colleagues of the impact that $75 billion worth of cuts in the Medicare program under the Republican health care bill proposal, the impact that's going to have on my rural health care providers. That's going to be on top of over $800 billion in cuts to Medicaid, Badger Care, as we know it in Wisconsin, and the disproportionate impact that's going to have on our rural providers. And I'll look forward to following up with MedPAC as you do a deeper analysis. It's my understanding you're not in a position today to comment too detailed as far as the impact that's going to have, but to follow up with you in the future so we know what to prepare for with the adverse consequences of those huge cuts that are being proposed in their legislation and the impact it's going to have in rural America and our rural providers. They're struggling already with the thin margins as it is, and this could just be adding on to their woes. And then finally, getting back to Mr. Higgins' line of questioning too, in the New York Times article that he cited, and that's in front of me today. And Mr. Chairman, I'd ask unanimous consent to have that article submitted for the record. It's dated May 15, 2017, authored by Mary Williams Walsh, titled "A Whistleblower Tells of Health Insurers Bilking Medicare."
Without objection.
Thank you. Obviously, we're talking billions of dollars potentially that are being affected by the upcoding issue. DOJ obviously has an interest in it. We're going to need, I think, more guidance and information from MedPAC as far as how real this problem is and what policy steps we ought to be thinking about taking to guard against the upcoding that potentially could be occurring and costing the Medicare program billions of dollars every year. So I think MedPAC's focus in this area in a more detailed fashion and recommendations that you're willing to bring forth would be helpful. Finally, and I've been almost a Johnny One Note on the need for delivery system reform and payment reform, getting to a more quality, value, outcome-based reimbursement system within Medicare, but throughout the entire healthcare system. But with your analysis with the Medicare program alone, what's your assessment of the progress being made as far as the integration and the delivery system reform proposals that are part of the Affordable Care Act or Obamacare now, as well as the alternative payment models and the value-based payments that are taking place within Medicare today? Are we making progress? Are we moving the needle?
I mean, what I would say is that there is progress in the sense that I think there is movement out in the environment and there's greater degrees of organization in terms of things like accountable care organizations, for example, that type of thing. I think what remains to be seen is how large of an impact those models are going to have. There is some evidence that they have affected spending, and also generally on the quality front, quality seems to be as good or slightly better in those kinds of models, which is not to be dismissed. But the kind of large spending impacts, that hasn't really materialized yet. And so, but there does seem to be a lot of motion out in the environment, so I think there's still things to be seen there. The other thing I'll say quickly about that is that this is a period where utilization slowed down historically, and then these models come in to try and control utilization. They may be having a harder time of it at the moment.
Okay, thank you. Thank you, Mr. Chairman.
Thank you. Ms. Chu, I'm sorry that I did not recognize you properly. It had nothing to do with my friend being from Wisconsin in the Big Ten country. Ms. Chu, you're recognized for 5 minutes.
Thank you so much, Mr. Chair. Mr. Miller, I am always concerned about my dual eligibles. In my district, about 1 in 5 or 35,000 people are dual eligible, and that is are in both the Medicaid and Medicare program. These people are often low-income seniors that rely on both programs for their care, which is often chronic and expensive. And nationally, about 10 million people are dually eligible. So I know that you have numerous proposals here to rein in spending on Medicare. But what would happen if there was a drastic cut to Medicaid? For instance, in the ACHA, there's a proposed $838 billion cut in Medicaid. But I would like to know what the impact on a big cut in Medicaid would be to Medicare.
In Medicaid, you're
Yeah.
saying? I don't feel like I've done enough work to either understand the nature of the cuts and what its backlash would be on Medicare. So I don't feel very versed in being able to answer this question for you at the moment.
Okay, then I will talk about a different topic, which is I was interested in the proposals to rein in spending on prescription drugs. And I know that there was the proposal to realign Medicare Part D and Part B drug coverage to better manage prescription drug costs, but that this spring MedPAC also voted 15-0 to recommend changes to how Medicare pays for prescription drugs under Part B, and that's expected to appear in your June report. You had several options for reining in those costs, and I noted with interest the ones to require prescription drug manufacturers to pay a rebate to Medicare if their drug price increase exceeds inflation, which is similar to the Medicaid inflation rebate, and also the proposal to create new private entities that could negotiate drug prices on behalf of physicians. Why did these proposals rise to the top, and how valuable would they be to rein in costs, and how viable are these proposals?
The Commission has been very concerned about drug costs and spending in Medicare and price growth. We spent a lot of time looking at Part D, and then it seemed natural to move to Part B. Part B, $26 billion, growing at something like an 8 or 9% growth rate, and we think a lot of that was price-driven. That's why these things rose to the attention of the Commission. You are correct in describing both of the things that you said. There is a rebate that says if prices grow faster than X, then the manufacturer is asked to rebate the difference back to the program, and then we would also tie the beneficiary's cost sharing to the lower growth rate so that the beneficiary also gets the benefit of the restraint on the, gets the benefit as well. And then your second point that you raised was we also said maybe like Part D, you have the physicians in Part B, because this is a physician-administered drug situation. organize, create formularies, and negotiate directly with the manufacturers to see if they can bring the price down even below what is paid now in the standard buy and bill sector. So we have said both of those things.
I guess what I was wondering is why those proposals came to the front, and was it because of viability, or would it rein in the costs more efficiently?
Oh, yeah, I'm sorry. I thought that was the first part of the response. This is a concern. It's a growth rate. This is a big spend. And yes, this would result in savings. Is that what you're asking?
I guess it's a combination of viability and reining in the costs.
Viability?
Yeah, whether the proposal would actually have some chance of succeeding.
I'd really have to defer to you on that. I mean, these proposals take legislative changes, and so whether they come to fruition is a function of the Congress. Is that what you're asking? Or am I missing you?
Well, I'll change to a different question, which
Sorry.
is about the astonishing price of generics and their drug prices increasing by 57%, but even more astonishing, the brand drugs increasing by 142%. Can you discuss why this dynamic is occurring and how this is affecting out-of-pocket cost to beneficiaries?
Yeah, and I believe both of those numbers come right out of our report. We track the prices overall and separately. Those are contributing to the point I made in the opening statement of driving more beneficiaries into the catastrophic cap. That drives the federal expenditures, and obviously to the extent that the beneficiary has to take a name brand drug and there isn't a generic substitute, then they're likely to be facing more out-of-pocket throughout the benefit period until they hit the catastrophic cap.
Thank you.
Okay. I'm sorry I missed your other question there.
The gentlelady from Tennessee is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you, Dr. Miller, for coming here and discussing the recommendations that are in the March report. As we take a deeper look into the recommendations and also the possible extension of several of the specific Medicaid programs that are set to expire this year, I think it's also important that we continue to pay attention to the future of Medicare program as a whole. I know these are very, very many specific things, but both the report and your testimony discuss solutions that go beyond simply updating payment provisions and try to more broadly address the fundamental problems with the fee-for-service program. I also noted in your testimony that you wrote that Congress should, and I quote this, enhance delivery system reforms that have potential to encourage high-quality care, better care transitions, and more efficient provision of care. And so with that, can you tell us what types of reforms, I know there are specifics in here, but other types of reforms that MedPAC would envision, considering this statement of the three pieces here, higher quality care, better care transitions, and more efficient provision of care?
Yeah. Let me just, okay. I think we would approach this from a couple of different perspectives. First of all, in the existing systems, even without major reform, we have tried to create payment incentives, as I've described a couple of times, so that there's not patient selection, there's not arbitraging, and we're trying to make link payments to quality measurements like avoiding readmissions, avoiding unnecessary hospitalizations, avoiding emergency room use, that type of thing, so that the experience of the patient is they get their care and then something doesn't go wrong and they have to go back to the hospital or go to the emergency room, and build in financial incentives to the provider that says, you know, if this happens, this is not going to play well in terms of your finances, that type of thing. But then we also have a set of thoughts where we have talked about delivery system reform, where you're trying to take the risk and the delivery of the care to the entire patient. And so there, I mean, we've made a number of recommendations inside the managed care space in order to address those types of issues, because there you have a model and a payment system where you're directed to the entire patient and you're trying to measure quality and outcomes for that patient. And so we've made recommendations there, which given time I won't blow through. And then the other thing that we've tried to do is support the development of similar models in the fee-for-service environment, like an accountable care organization, and how a set of fee-for-service providers can have a top-line, benchmark and manage against that with quality metrics and manage against that benchmark so that they can control expenditures, improve the quality of the beneficiary, but again, thinking about that beneficiary as their entire experience, not a specific set, this service or that service. And we've made a set of recommendations and given advice to the Secretary on how to improve the accountable care organization. The very last thing I'll speak to very quickly is we've also, and this will be in our June report, been having some conversations about how to reorient MIPS on the physician side and the APMs on the physician side, or broader than the physicians, but on the physician side, in order to get more of this movement to kind of an organized look at the beneficiary as a whole experience rather than service by service. So there's sort of 3-4 areas in there.
Yeah, so you just spoke about models. Are there any models that are being tested that you would come back and say these models are being tested and this is what's working or not working?
There's a number of models that are being tested in the CMMI, and both at the patient level, ACOs. There's a model around chemotherapy and oncology services, sort of building a bundle around that. There's models around different post-acute care types of experiences, kind of a smaller episode, not the whole patient episode. There's not a tremendous amount of kind of final, clear evidence that says, and this is sort of related to a question over here, that says, this is working, everything's good to go. That is still, feels like it's not quite there yet.
Thank you. Yield back.
Thank you, and last but not least, Ms. Sewell is recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you, Dr. Miller, for being here today and giving us your insight on the current state of Medicare. My home state of Alabama has the 4th highest rate of Medicare beneficiaries in the country and the lowest hospital Medicare reimbursement. Our population is very dependent upon Medicare, and we often feel that the way the wage index works against us is not very fair. This is quite alarming to me, not only because it seems unfair, but also when you think about the fact that we are contemplating making Medicare trust fund even less solvent. It just means that we need to make sure as policymakers that we are not going in the wrong direction when it comes to Medicare and Medicaid. As I visit my hospital administrators and physicians and nurses across my district, I'm concerned about the impact of proposed Medicare cuts and Medicaid's uncertainty on primary care shortage. I have an article that I'd like to submit for the record about the primary care physician shortage in the Black Belt rural counties of Alabama that was in the New York Times.
Without objection.
Thank you. The county, Perry County, which is in my district, not only does it have one of the lowest number of doctors, I think it only has 2, and only has 2 ambulances, but most recently it had a terrible outbreak in TB, tuberculosis, and it was 100 times higher than the national average and higher than rates in India and Kenya. So you can imagine I was quite alarmed having that right in my backyard in my district. There are only 3 physicians countywide, and only 1 is in Marion, where most of the outbreak was. Studies indicate that the addition of a single primary care physician to a community causes the local economy to grow. Unfortunately, it's predicted that America will be short as many as 30,000 primary care doctors by 2025. And your March 2017 report, the nature of the fee-for-service payment leads to quote, undervaluing of primary care, end quote. So Dr. Miller, my question is, can you expound upon the report's findings with respect to primary care and the salary disparity between primary care and specialty care and the impact that it has on our shortage, the shortage?
Yeah, I think I can. And, this is an issue that the Commission has pursued for several years, and so it shows up in several reports. And a couple things to keep in mind, and then I'll get you to what we've said about it. You know, one of the phenomenon is if you're a proceduralist, you have a greater ability to create new codes because things are more likely to be new there. They get priced at a certain level, and then if they, over time, should come down because people become more efficient, spend less time doing them, they don't necessarily always come back down. And also as a proceduralist, you generally have more opportunities to generate volume. So for many years, the Commission is saying there's been this problem in the fee schedule, and you've tracked on it exactly. You know, your earnings, if Medicare were to pay for everything, but even if you look at it at all payer, look like this between sort of the procedural versus the primary.
And it often has a bigger effect on rural hospitals and rural communities.
Right.
More of a
That is correct,
impact.
because in rural areas, there are more primary care physicians. So we've made recommendations over time to rebalance those dollars and increase the payments to the primary care side of the fee schedule. The Congress actually did take action on that, but then it sunset. And so there's that issue's out there. You're exactly right. I was going to say this, but you said it first, which is that does have an indirect effect on rural areas because they tend to have more primary care. And then the other thing that we've been talking about lately, this isn't a hard and fast recommendation, but we did make this recommendation at one point, I think, where you might begin to say for the primary care physician, if you make that add-on payment, instead of making it service by service, you make it per patient. And that way, the provider has flexibility. It doesn't have to keep seeing patients to generate revenue, but can use that revenue to do things like spend the afternoon on the phone doing care coordination, hire a nurse practitioner to help with the coordination in the office or whatever the case may be. So there's been thinking like that along those lines.
You know, since my home state of Alabama has one of the lowest wage index, I've introduced a bipartisan bill with my colleague, Diane Black. I want to thank you for that, which would provide more equity in the area of wage index formulas by creating a floor of 0.876. Many argue that hospitals in rural and low-cost areas should simply raise their wages. What reforms need to be made to the formula to provide more equity to the current reimbursement structure?
So the gentlelady's time has expired. Could you and your staff reply to her in writing?
Can I say 5 words?
5 words.
We have a recommendation on that. I don't know how many words that was.
That was pretty impressive, Dr.
So we can
Miller.
help you.
Mr. Reed, you are recognized for the final 5 minutes as the vote has begun.
Well, thank you, Mr. Chairman, and I'm way over here, and it's good to see you way over there. Thank you, Dr. Miller. I wanted to follow up on my colleague from Oregon, Earl Blumenauer's comments about hospice and the hospice recommendation in your bill. I also am very committed to hospice and palliative care across America and work with my colleague quite a bit on it. So as you looked at the hospice update and did not recommend any update in the MedPAC recommendation, my understanding you also look at quality of care in coming at that determination. Could you give me any feedback as to what you're seeing in the quality of care in the hospice environment that you saw in the report?
Okay, this has been very difficult to track because there hasn't been until recently a lot of good measures of quality, and recently CMS has begun to collect up measures. And so I'm not exactly, prepared to tell you how the quality profile looks these days because it's sort of just coming online. It might be actually measurable, but at this particular moment I'm not able to pull it up. But I will say this. One of the things that we've been thinking about beyond what has been being collected is looking at things like this. Live discharges. We think live discharges, if you have a lot of those, are an example of potential quality issues and other issues, quite frankly. And then also there are issues around the skilled or the presence of a hospice provider in the patient's home in the late stages, and whether those there's enough of that going on when the patient enters their late stages. So those are a couple of areas that we've been looking at. And then, as I'm trying to say, not very articulately, there is a new set of measures that were put in place and are starting to come in now, I think, although I may need to double-check exactly where all that stands.
I would appreciate if you get that information, if you could share it with our office.
Absolutely.
I'm very interested in looking at those impacts, because I'm a firm believer, not only does this hospice and palliative care make a good fiscal sense for the purposes it serves, but also the quality of care to patients. Being a hospice volunteer myself here in D.C., I can attest anecdotally to the benefit I've seen in patients of hospice and palliative care. So on another topic, another issue, I come from Western New York. It's a rural section of New York where the Finger Lakes, Corning is my hometown. And one of the things that I worked down here extensively since 2010 is on the Medicare-dependent, low-volume reimbursement policy. Peter Welch on the other side and I have teamed up, Peter Welch off this committee, but teamed up on this issue. Can you give me any indications as to why that reimbursement policy makes sense, especially in a rural environment, and what do you see on the horizon, the pros and cons of extending that permanently?
And the it in this sentence is the low volume and the Medicare dependent.
Medicare dependent and
okay,
the two different reimbursement policies.
Yeah, two quick comments, and I realize we're time limited here. We're the people who actually recommended a low volume adjustment. We support that in concept. Unfortunately, the way it was implemented was not the way to implement it. So here's the way to think about it. Let's say you and I both have you have 1,000-person admit hospital, and I have 1,000 admit hospital. That's low volume, and that means we probably are struggling with covering our fixed costs. But the way it was implemented, it said Medicare admissions. And so that means if most of your admissions are Medicare, but only some of mine are Medicare, I get help, you don't. And yet we both might be in the same boat. And so we are thinking reset the metric so it ties to total admissions, and we have some ideas of where that cutoff should occur. The other thing I would say on the Medicare dependent and the low volume is they're often aimed at the same objective, helping a hospital that's struggling with fixed costs. We are concerned about some duplication. Some hospitals are pulling both, and maybe that's not an exact great use of a federal dollar. And then on the Medicare dependent hospital issue, there's this notion. It may make sense as an adjuster, but all of these rural adjusters, be conscious of the fact that you're not giving it to hospitals that are 10 miles away from each other. Then you may be propping up two, operations that just aren't going to economically ever be efficient, and maybe it needs to be some consolidation and then a subsidy there.
Okay,
so that's the two thoughts.
Well done. With that, I yield back.
Thank you, Mr. Reed, for your leadership in this issue as well. Dr. Miller, thank you for your time, your incredible patience, and your expertise in sharing that with us today. These are important issues. Ensuring the efficiency of Medicare for future generations is something that we should be, in a bipartisan way, all working together on, not just in this Congress, but in future Congresses. And we look forward to having you back in the future.
We appreciate it.
Thank you. Please be advised that members will have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. With that, this hearing is adjourned.